I will call today's meeting of the Green Mountain Care Board to order. It is Wednesday, July 15th at 10:30 a.m. And I would first like to approve our minutes from July 8th.
Second.
Great. All those in favor, please say aye.
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 Okay. I am going to hand the meeting over to Hillary to go through our speakers and our agenda.
Great, thank you, Member Teachout. Can folks hear me okay?
Great.
Okay, wonderful. And Ellie is bringing up some slides here to move the board through deliberation, and a potential vote has been noticed regarding the Agency of Human Services Healthcare Workforce Development Strategic Plan. Wonderful. I see the slides. Everybody can see those okay? Okay, wonderful. So as mentioned, I am Hillary Watson, Project Director for Quality Access and Planning on the policy team. And I've been one of the staff members helping to coordinate the board's review of this strategic plan. Similar to last week, I just wanted to bring a couple of those grounding slides back up and run us through the process, and then I will turn it over to Ellie, Katie, and Gaurav Kalwani, who will share an overview of the public comments received. So after our brief intro, Member Teachout, we'll hand it back to you and we can review the draft motion language and facilitate today's discussion. So the next slide, please, Ellie. Thank you. As I mentioned, these are the same slides that we presented last week. I just wanted to remind folks of the guiding statutes here. So 18 VSA 9491 is the legislation that requires the Director of Healthcare Reform in the Agency of Human Services to maintain a current healthcare workforce development strategic plan. And then on the board side, 18 VSA 9375 details the duties of the board. One is to review and approve the Healthcare Workforce Development Strategic Plan. So next slide here is just, again, a refresher of our timeline and the process that we've moved through over the last number of weeks here. So AHS submitted the plan to the board on April 16th. Last week on July 8th, they presented an overview of the plan, and the board had some discussion and heard some public comment in the meeting. Recording of that meeting is on the Green Mountain Care Board YouTube site if anybody wants to watch it. Then between July 6th and July 14th, the board opened a special public comment period and welcomed members of the public as well as members of the Green Mountain Care Board's General Advisory Committee to provide comment on the draft plan. And we are here today, July 15th, for a board deliberation and potential vote to approve the plan. So now I will turn it over to Ellie and Gaurav to share what we heard in public comments. And I also just want to mention this is Gaurav's first time presenting to the board, and I wanted to welcome you, Gaurav, and express my gratitude, and so glad you're part of the team.
Thanks, Hillary. Hi, everyone. My name is Ellie Katie, and I'm a policy analyst on the Quality Access and Planning team. So along with my colleague Gaurav, we're going to share a summary of the public comments received. These comments have also been shared with AHS. So in total, we have received 8 public comments and have identified 4 common themes. So the first theme we identified from comments is related to data and measurement issues. So specifically, it was cited that there needs to be more attention to the granularity of the data. So this includes a recognition of the disparities in the labor supply, specifically between Southern and Northern Vermont, and that data should be specific by health worker type. The second theme identified from the public comments is focused on some of the perspectives that are missing from the plan. So comments shared the need for perspectives from independent physician-owned practices, primary care physicians, ambulatory surgery centers, and specialties like anesthesia, radiology, and physical therapy. It was also recommended that the advisory group should add a representative from the ambulatory and independent care settings. And I am now going to turn it over to my colleague Gaurav.
Thank you, Ellie, and thank you, Hillary, for that warm welcome. Excited to be presenting here for the board. So these are the third and fourth themes that we identified in the public comments that we received on the Workforce Development Plan. The third one was additional recruitment and retention strategies being needed. In general, there were comments about more integrated strategies needed to address non-clinical or non-workforce issues within the clinical setting, such as housing and childcare for the healthcare workforce. More strategies on incentives for recruitment and retention generally, including scholarships, loan forgiveness, and competitive salaries. There was a specific focus here, especially on the primary workforce, given the shortage of PCPs in the state. And then finally, the incorporation of regionalized and shared staffing strategies across healthcare facilities in order to alleviate some of the labor burdens. Finally, the last theme we identified in the comments we received was the need for more specific implementation details and accountability measures within the plan. These could be anything from numbers to percentages to targets for recruitment, but the comments identified a need for those sorts of specific measures to understand how the progress of the plan is continuing as it's being implemented. And I'll turn it back over to Hillary. Thank you.
Wonderful. So the next two slides offer up some draft motion language for the board to consider. The first is an approval of the Workforce Strategic Plan as submitted. And then the second slide here includes some alternate motion language, which is a conditional approval of the Workforce Strategic Plan, and the following conditions would apply here. So AHS shall add a primary care provider recruitment and retention strategy to the document following consultation with the Primary Care Steering Committee. And the second condition would be for each strategy outlined in the plan, AHS shall identify the entities responsible for carrying out the work and those accountable for ensuring its successful implementation. So I will turn it back over to you, Member Teachout. Thank you all so much.
Great. Thank you, Hillary, Gaurav, and Ellie for all of your work on this. Do you want to leave the slides up or take them down?
Whatever is easiest for you and the board members.
Okay. And is it my understanding that Suzanne Trombley also wanted to speak?
Suzanne was on the line here. Suzanne, did you want to mention or make a few comments?
Yes, if you, I would thank you for the time to speak. I wanted to take a moment to thank the board and the public for your time, your expertise and thoughtful recommendations. We're committed to incorporating your recommended next steps into our implementation planning. And we do recognize the call for immediate action, and we'll move swiftly to translate the plan into actionable and measurable next steps. We're going to prioritize on-the-ground efforts and the identification of high-priority sectors, regions, and professions while shaping sustainable best practice solutions for the long term as well. And we are committed to promoting transparency and accountability, and will provide regular public progress updates. And I just wanted to thank you again.
Great. Thank you very much. And thank you for speaking. So if there's nothing else, then I would see if we wanted to have discussion or make a motion about the report.
I'm happy to jump in here, Sarah, member Teachout, acting chair Teachout today. Lots of titles for you. First of all, I definitely want to acknowledge the hard work that Suzanne and your team have done on, pulling together this strategic plan. And I really appreciated the public comment that we received. It was very thoughtful, very thorough. And, it impacted some of my thinking on the strategic plan. So that alternative proposed language was something I shared this morning with Hillary. I do believe that more emphasis needs to be placed on primary care recruitment and retention strategies. And I think with consultation with the steering committee makes a lot of sense. I very much appreciated that public comment last week. And as I said last week, any strategic plan dies on implementation if there's not, frankly, folks listed who are going to be accountable and responsible. And I want to make sure that this strategic plan, which has some, meaningful measures to ensure that we have a stable workforce to deliver the healthcare that we know that we need, with the headwinds that are coming our way. So I proposed some that second condition, which is to ensure that the plan, to ensure that that plan is actually implemented, that we have folks accountable for execution of the plan and identify the folks who are going to, or the entities that are going to be responsible for making sure the work happens. So I put that out there. Thank you, Hillary, for adding that alternative language to the slide deck. I would welcome any discussion from my colleagues on the board and public comment about it, but I thought those two conditions would make me feel more comfortable in approving the plan. So that's
Great.
my
So-
thinking on that.
Member Holmes, is that your official motion?
I'm happy to make that motion. I can make that motion. If you want to bring it up, I can read it out loud and move that we can start a discussion around that and see if Hillary, if you have that, or Ellie. Okay. Yes. So I would move approval of the 2026-2028 Healthcare Workforce Strategic Plan submitted by the Office of Healthcare Reform, subject to the following conditions. One is that AHS shall add a primary care provider recruitment and retention strategy to the document following consultation with the Primary Care Steering Committee. And two, for each of the strategies listed in the plan, AHS shall identify the entities responsible for carrying out the work and those accountable for ensuring its successful implementation.
Great, thank you so much. So is there board member discussion or thoughts on the proposed motion? And there
Do we want
Even
to
is there a
see if there is,
second?
is there a sec? Yeah, do we want to?
Yeah, is there
Oh,
a
yeah,
second? I
sorry.
think we need first. Yeah, nope.
I'll second it. And I might have some amendments to your amendments, but generally speaking, well, I really appreciate the hard work that goes into these. These are complicated plans. I've tried reviewing some other state plans. There's, this is a broad plan that tries to address multiple different areas. I do feel that the public comment was super helpful and I think resonated with me, and I think I had some similar thoughts, which was and I expressed this last week, I believe, I was a little concerned about that there isn't a whole lot for providers, physicians, and advanced practice providers in here specifically called out, and I have some concerns for that. I mean, just thinking about the challenges that Copley Hospital had with recruitment of obstetrics in Brattleboro, I think similarly, reliance on locums, it really impacts the ability to provide services in Vermont and the financial health of our organizations if hospitals are reliant on locums physicians. I think another area which was called out in a public comment was anesthesia. I mean, anesthesia is a huge pinch point and a very complex problem these days. There's a huge shortage of anesthesia nationally. So how we want to think about our CRNAs and anesthesiologists, workforce development, retention, recruitment. They're required for so many of the sort of pinch points in our healthcare system and delivery system, especially on the very high cost side where there's lots of procedures that are being done that are important. So in addition to primary care, I do think there's other areas of physician recruitment, retention, development, workforce development, and regional strategy that I think could be considered in this plan. I think in general, I appreciate Member Holmes's identification of responsible parties, but the monitoring implementation component of the plan says each strategic goal and its strategies will be supported by a comprehensive work plan detailing activities, timelines, and responsible parties. And I guess for me right now, I have a hard time feeling comfortable approving the plan without some more comprehensive work plan timelines, responsible parties, in addition to what I had mentioned before. So I'm sort of on the trying to decide whether or not I would feel more comfortable delaying approval of the plan until we had further detail, or amending Member Holmes's conditions to include comprehensive work plan detailing activities and timelines in addition to the responsible parties, so that we can make sure that this plan does what Professor Dr. Member Holmes says, and I think she deals a lot with strategic plans, is every good plan dies in implementation if it's not really carefully accounted for. So I want this to happen and go forward and not get lost. And so that's sort of my thoughts on this is, should we delay approval for more detail, or should we condition approval on more detail coming? Either right now is something I would be comfortable with, but as it stands without more detail and having these responsible parties and details and timelines identified, I think I'd be uncomfortable.
Great, thank you. Member Walsh, do you have comments?
Yeah, sure. Thank you, Member Teachout. And thank you for AHS for the presentation and walking us through this. As other board members have said, we recognize it's an incredible amount of work. And I too found the public comment period especially useful. We often receive wide-ranging public comments. In this particular case, they really honed in on a couple useful things. And I appreciate Member Holmes' addition conditions. I've been struggling, it sounds like, Member Merman. There's a lot to like, a lot to appreciate about the plan. There are some concerns, although not to the point where I was considering not approving the plan. The persisting concerns that I've had that I think are more questions that I hope would be some type of useful advice, but again, I wouldn't vote no on approving the plan, but I think there could be some additional clarity about addressing workforce shortages. There are different types of shortages, numerical and functional. That difference is important because the remedies are different. And if the approach is to just try to increase numbers when there are functional shortages, that does not work. And it risks worsening the affordability crisis that we have in the state. I think that's one of the biggest things. I'd like more clarity in the plan about how priorities would be set, how they'd be adjusted over the time, and how the public would know that transformation is actually happening. I didn't see those type of details. I think those types of details would strengthen the document. I did have one, again, not so much of a concern, but something that I did notice in the additional documents that were shared with us last week. The Rural Health Transformation Fund Notice of Funding Opportunity describes funding coming to the state from the federal government that must be spent prior to when the strategic plan is required. The first year of rural health transformation funding must be spent by July of 2027. The announcement for the statewide transformation plan being completed is not till December of 2027. So that timeline is a bit disjointed, and I don't think there's anything that we can do about it because some of it's the fault, the federal government is responsible for some of that. But it does create a worrying situation where millions of dollars are flowing into the state for transformation prior and have to be spent prior to there being a plan. Once that money is spent, how will that impact the plan? So those are considerations that I hope people will take up. I think they would strengthen the document. But again, I feel comfortable approving the plan. I think the conditions are welcomed and the public comments were informative.
Great. Thank you, Member Walsh. So on how to move forward, we could continue with the motion that's been put on the table and seconded. We could entertain an amendment to the motion. And then also I would like to hear comments from the Office of the Healthcare Advocate and then the public. So first, I think first maybe some comments. So first, is there a comment from the Office of the Healthcare Advocate?
Yes, Acting Chair Teach Out. Mike Fisher here. I don't know whether camera functioning is working. Thank you for asking. We don't have a comment from the Healthcare Advocate, though I very much appreciate the dilemma that the board is in and the framing of the question that Member Merman phrased about sort of what's the right order to do things in. And I appreciate the dilemma you're in, and either of those spelling out what you're expecting from the plan in advance or waiting until you have those details makes sense to me too. Thank you.
Great, thank you. So I think I'll next open it up and see if there are comments from the public. And I'm not sure if I can see all the hands, if there are any. I believe I see Mr. Carpenter. Go ahead.
Hello, Acting Chair Teach Out. Just a real quick question more. I haven't been able to really read the plan yet because I've been working too much, but is there any mention of actual working conditions inside? Because this affects workforce shortages quite a lot. Pay, benefits, that kind of thing. Working 10, 12-hour shifts, being short-staffed, overworked, burned out. Is there any kind of mention on that in the whole thing? And I do back up Member Merman's concerns.
Great. Thank you for your comment. And I'm not sure I personally have an answer.
Walter, I can, is it all right if I just pop in? There is a section goal. It's the first goal is actually to cultivate a supportive and engaging work environment that prioritizes employee retention, satisfaction, and overall well-being, thereby driving operational success and sustainability, which in its detail, like a little level, increased level of detail does discuss, I think, some of what you're bringing up here. So I think the plan actually does get into that. It's general across all different levels, but not. But again, it's a broad plan, but it's in there.
That's a big one.
Great, thank you. Any other public comments? Again, I'm not seeing all the hands. So, okay, I'll return to the board members to talk about how we want to move forward. I'll confess I have a slight preference for approving the plan, just so we can get moving. But also I'm open to additional requirements here or amendments to it if we wanted to do that going forward. We do have the motion on the table.
Can I ask a question about the motion largely for anyone? Is on the number 2, for each strategy outlined in the plan, AHS will identify the entities responsible for carrying out the work and for those accountable for ensuring its successful implementation. Do we have I guess we should probably add some sort of time component to this, by a certain date, or I don't know how others feel about that, if we could add a date to that. And then my other preference on that would be to add some additional language as referenced in there monitoring and implementation section regarding each strategic goal and its strategies will be supported by a comprehensive work plan detailing activities and timelines. So maybe for each of these strategic goals, we could see a work plan, timelines, and responsible parties by a certain time, date, and
Great.
I think to
Member
allow
Walsh.
us to understand, like when this could happen.
Sure. Member Walsh, go ahead. And then you were concerned about the timelines, I remember. So maybe that would be helpful to your thinking on how to pull it together.
I appreciate Member Merman's comments, and I wonder if for item number 2, it's for each strategy outlined in the plan, there will be a comprehensive work plan that and timeline that identifies the entities responsible for carrying out the work and those accountable for ensuring its successful implementation prior to the start of that work. So if there's a strategy that's being addressed, it sounds like what Member Merman's asking for is a plan and timeline. And what Member Holmes is asking for, that it identifies who's responsible and who's accountable, that we would like that in place before the work is commenced. I think that would need to be cleaned up with that language, but I think that's what I'm hearing.
Member Merman, go ahead.
The one concern I would have with that is I don't want to delay the work from commencing. I want to encourage the work to commence sooner. And so if we set I'm hypothesizing if we set a date, that then it would force the completion of the plan to the point that the work can begin. That's just a thought.
Member Holmes?
Yeah, I was just going to say, I think having a full comprehensive work plan is really important. But if we need a timeline for that may take a little bit of time, right? The implementation plan is the detailed granular implementation plan may take more time that I'm not sure we want to delay. But I do think knowing who's responsible and who's accountable for each goal and strategy should be a reasonable thing to do in short order. And so I might, and Suzanne is on, so we might ask for what is a reasonable time horizon for identifying the accountable and responsible parties for each strategy. And I think there's another way of the monitoring component, Dave, that you mentioned is, we could invite AHS to come back and talk about that detailed work plan. And we could also ask for it to be posted, on their website, and having an implementation plan, timetable, or, this is something that's in progress. This is something that's already complete, so that there's a way for the public to track progress on each of the initiatives. Could be posted online potentially, but I'd love to ask Suzanne her thoughts on this since she is on this call. But I think what we're asking for, I think broadly speaking, is a little bit more detail on who's accountable and who's responsible before approval, and then a plan for how there's going to be monitoring and transparency in the execution of the plan. And whether that's posting it on their website with progress reports, or whether it's coming and, potentially sharing some of that progress, wonderful, hopeful progress with the board. I think both of those things, maybe Suzanne might be able to weigh in on before we vote.
Great. Suzanne, would you like to comment now?
So I don't want to commit to any timeline, broadly speaking, that's before August 5th, which is my next strategic plan advisory group committee meeting. and it's scheduled. It's a half-day retreat where we have an opportunity to really delve into what that implementation, who's responsible, some more specific timelines. And I think that a really great update could happen post that retreat and that meeting that would be able to address the alternative or alternate motion language that you've discussed. As far as implementation planning, there is a significant amount of work already happening in that area. So, I mean, I don't want to pigeonhole myself, but I think that I could by the fall have a pretty decent work plan and implementation plan ready for you and the committee.
May I ask a question, Member Teach Out?
Please.
Of course.
Acting Chair Teach Out. I wasn't sure whether we have a timeline or there is a timeline, a statutory timeline on approval. And I'm just wondering since August 5th is coming up and there is an opportunity to do condition 2 potentially at that meeting. I mean, would you come away from the August 5th meeting with the ability to, for each strategy outlined in the plan, identify the accountable and responsible parties in such a way and that the strategic plan would be a little bit more complete in that regard, and then we vote on the updated strategic plan after that August 5th meeting? Just throwing that out there as an idea, since that date seems to be coming up and that retreat might actually fill out some of this information that others may need on the board.
If you're asking me, I feel confident that yes, we could bring that back to you fully articulating into the plan this language and coming up with some great timelines and implementation steps.
Thank you. And I guess the one question for you, Suzanne, is it necessary for us to approve your strategic plan now to get things moving, or is it okay to delay until after that meeting and we get further detail?
I think a delay is fine because the August 5th meeting is that next step anyhow.
Okay. Thank you. I appreciate that. So is it the board's preference to delay a vote on this until a later time? Member Holmes, I'm just going to ask you. Straw poll.
Yes, I think that sounds
Okay.
reasonable to me. I think
Okay.
so.
Okay. Member Merman, is that okay with you?
Yeah, I like that idea, and I think it gives opportunity for integration of some of that public comment information in there as well, which I think it sounds like you're committed to, and I think that'd be great to add in and just sort of have it as part of the plan.
Okay. And Member Walsh also?
Yeah, I think that's a good plan. And I appreciate Suzanne's willingness to collaborate with us in arriving at that plan. It's evident she's trying to take all this in. And hopefully we keep moving forward.
Great. Okay. So I guess the only technical question I have is, Member Holmes, do you need to withdraw your motion?
Happy to withdraw.
Okay. Thank you, just in case. So I think that's what we'll do. Thank you everyone for presenting and providing comment. We really appreciate it. And so we'll pull this motion language down, hopefully, and move on to our next agenda item and delay this until after the August 5th meeting that you have, Suzanne, and we'll reschedule you. Thank you. So I think, Hillary, you're up again, right?
I am. Sorry to be taking up so much airtime today, but it is nice to be with you all. So just again, for the record, I'm Hillary Watson, the project director for the Quality Access and Planning team on the policy team here at the board. And just wanted to kick off my remarks by mentioning that, while I'm the one sort of starting our presentation today, I just want to take a moment to recognize that I'm really far from alone in this work, and there's an incredible team effort here that really deserves highlighting. So I just want to give a shout out to Ellie Katie and Gaurav Kawani, who you just heard from briefly a few moments ago in the workforce presentation. And they are two new team members who just joined the board in the last couple of months and have really truly hit the ground running with this work, and have been, we as a team have been further supported, by leadership and the broader policy team and our legal, finance, and data teams as well. So I just have some brief introductory remarks here. Then I will be turning it over to our presenters today. We are very excited to welcome colleagues from the Vermont Program for Quality in Healthcare, VPQHC, who will be providing an overview of their organization, the Medicare Beneficiary Quality Improvement Program, as well as their administration of the state's Patient Safety Surveillance and Improvement System. I'll then turn it over to Kathy and Colleen from Healthcare Association of New York State to share an overview of the CMS 2026 hospital star ratings, as well as 3 CMS pay for performance programs. Dr. Tom Weigel from Blue Cross Blue Shield of Vermont is also here with us today to provide an overview of their approach to value-based care. And while not present today, I did want to mention that we also connected with MVP Healthcare as we were planning today's board meeting. And while schedules, did not align for them to join the call, they really did express a genuine interest in being a part of future quality and access discussions. So we look forward to engaging with them as we continue this work. And last, we are glad to welcome colleagues from the Blueprint for Health at Vermont Agency of Human Services. So Dr. John Soroyan has been their executive director for 4.5 years, and Aaron Just recently became the deputy director of care transformation at AHS after serving in a contractor role as the statewide quality improvement coordinator for Blueprint. So we are grateful for our presenters' willingness to share their insights with us today. Quality and access are multifaceted domains that really benefit from shared understanding, defined roles and responsibilities, alignment, and sustained focus. So we all hold a piece of ensuring that the needle moves in the right direction, and we are excited to learn alongside the many entities that support Vermonters' access to high quality, affordable, and accessible care now and into the future. So the next slide, thank you, Ellie. This is not, new news to anyone, but always a helpful reminder of why we are here today and why this work is so important. The board's mission is to drive system-wide improvements in access, affordability, and quality of healthcare to improve the health of Vermonters. And our levers for driving those improvements include, regulatory, monitoring, evaluation, and transparency duties and responsibilities. So drilling down a bit deeper, we thought it would be helpful, shout out to our legal counsel here, to pull out some of the guiding legislation dictating the board's role in ensuring that Vermonters have access to high quality care. So this slide has lots of words, my apologies, but it is such important detail that it's hard to pare it down. But I just wanted to highlight a few pieces here. First and foremost, the board executes its duties consistent with the principles of healthcare reform as stated in 18 VSA 9371. And these principles recognize the need for universal access to and coverage for high quality, medically necessary health services for all Vermonters, and the need for Vermont's healthcare system to continuously evaluate and improve healthcare quality and safety. These principles also recognize that cost is a barrier to accessing necessary healthcare. Under that charge, specific duties have been assigned to the board that help define our role and obligations in this space. So 18 VSA 9375 tasks the board with overseeing the development and implementation and evaluating the effectiveness of healthcare payment and delivery system reforms designed to control the rate of growth in healthcare costs, promote seamless care, administration, and service delivery, and maintain healthcare quality in Vermont. Importantly, the legislature has mandated that the GMCB develop and maintain a method for evaluating system-wide performance and quality, including identifying the appropriate process and outcome measures. Additional legislation requires the board to develop methods for measuring, reviewing, assessing the impacts of actions on, and monitoring quality throughout sectors of the healthcare system. So the next slide is just an opportunity to share publicly about restructuring of the policy team. I want to recognize Alina and leadership's dedication to organizing the team in a way that aligns with our triple aim. I'll just highlight that although the Green Mountain Care Board has long had quality as part of its mission and duties, it was really only recently in 2025 that the legislature awarded dedicated positions to begin doing this work in a more structured way. And since then, we've been developing our approach, building our team, and really thinking about how we incorporate quality into the board's duties around evaluating the performance of the health system and across all of our regulatory responsibilities. So it's been a really exciting opportunity to grow this team. And while we are still developing our work plans, we did want to share a little bit about our culture and approach. In our early days here, we've really been leaning into these pillars to guide us. You know, we appreciate the opportunities that stem from collaboration and consistent communication. We continue to learn so much from those that we are speaking with, and we have many more folks to outreach to. And we're really trying to ground our work in evidence and best practice and develop a deeper understanding of operational realities and barriers that challenge progress. I think it's also important to note that it is our hope to seek alignment and build on what has been done and what is working well. The worlds of quality and access are vast, and we really want to be thoughtful, informed, balanced and strategic in our approach so that systems can really benefit from shared focus and goals. Lastly, we can't underscore enough that, we really want to promote continuous improvement. We don't want to take our eyes off the ball here, and we really want to ensure that our systems and processes, provide transparency into how and where quality and access are changing. So last couple slides here, circling back to those legislative charges, there are many opportunities for our team to dig into existing and new bodies of work. We look forward to what is ahead and working with the board, other branches of state government and provider networks, regulated entities, the healthcare advocate, and the public to help realize and build this work out. So one last concrete kind of project to highlight is that Act 68 of 2025 provided funding for the Green Mountain Care Board to contract with VPQHC to engage in quality initiatives in accordance with the Act. So after working with VPQHC and the Agency of Human Services, the early spring here, we defined the scope of work for that contract and landed on two deliverables. One being an assessment of Vermont's healthcare quality quality infrastructure, and a second being the development of an inventory of quality measures. We're excited about this work. It has recently kicked off, and we really look forward to how it will inform, our planning efforts as well as those of the Agency of Human Services as they lead the development of the statewide healthcare delivery strategic plan, which is due in 2028, and the health system transformation work that's taking place now. So that is what now feels like a very long-winded intro. I was hoping to keep my remarks very brief, but I'm excited to turn it over to Mary McQuiggan, the Director of Programs at VPQHC. So thank you very much, Mary, and I will turn it over to you.
Thank you, Hillary. And thank you, Randy, for pulling up our slides. Thanks everybody for the opportunity to be here. I'm the Director of Programs at the Vermont Program for Quality in Healthcare, also known as VPQHC, or sometimes we even shorten it even more to VPQ, because it's such a long name. Randy, could you go to the next slide, please? So I'm going to give a brief overview of VPQHC, and then I'm going to pass it along to my colleagues to talk in more detail about some of our work. So VPQHC is a statewide healthcare quality improvement organization. We were established in the late 1980s, and our role is codified in Vermont Statute 9416, and we have several different funding streams that support our work. And we're unique in that we're independent, non-regulatory, and improvement focused. We partner with healthcare organizations across Vermont to use data, evidence, and collaboration to improve quality, patient safety, and health outcomes for Vermonters. Next slide, please. So we have a really incredible team. We're very fortunate to have such a great team with folks who have expertise in quality improvement, patient safety, data and analytics, public health, healthcare operations, and clinical care. We all feel very privileged to do this work and to be able to partner with the healthcare organizations across the state to improve the care for Vermonters. Next slide. So this slide tells you a little bit more about what we do, but it really just highlights the primary ways that we advance our mission and how we organize our work into several core areas, from quality improvement and patient safety to coaching, mentorship, education, and statewide collaboration. Next slide. So VPQHC is overseen by a board of directors. We're really lucky to have a really great board of directors with representation from across the healthcare system. They really help guide our work, maintain our independent statewide perspective. And our next slide gives you a quick snapshot of VPQHC's work in 2025. We worked across a variety of healthcare settings and topic areas, and we partnered with organizations throughout Vermont, reaching thousands of healthcare professionals. For today, we're going to be talking about just two of our programs, but we're always happy to come back and discuss our other initiatives or to serve as a thought partner on healthcare quality. So with that, I'm going to pass it over to my colleague, Randall Messier, and he will provide an overview of the Medicare Beneficiary Quality Improvement Program, also known as MBQIP. Thank you.
Thank you, Mary. As Mary said, I'm Randy Messier. I'm the Senior Quality Improvement and Patient Safety Advisor at VPQHC. And it's our pleasure to share with you some of the work that we're doing with some of our critical access hospitals here in Vermont, and specifically around the MBQIP program. So I'll be talking about the MBQIP program in a quick overview. What are the core measures that establish this program or part of the required reporting requirements? Some of the platforms that are used to get this data into the systems, and then how this data is used and shared with the critical access hospitals to help with their improvement efforts. Okay, so what is MBQIP? MBQIP is part of the Health Resources and Service Administration support of critical access hospitals across the United States. There are 1,368 critical access hospitals in the US. Almost all of them participate in MBQIP. And in Vermont, we have 8 critical access hospitals, and all of them participate within this program. So we are contracted with the Vermont Department of Health and the State Office of Rural Health and Primary Care to administer this program. We provide technical assistance and quality improvement support. My colleague and I were on this morning with one of our hospitals providing some support for them on some of the CMS star rating reports. We provide an MBQuip data dashboard that we provide to Vermont Department of Health twice a year. We provide education and learning collaboratives around quality improvement, around measurement, and help support the collaborative improvement efforts going along across the state. EDTC data, this is data that's captured around the transfer of patients from emergency room to other hospitals. We'll talk more about that in a minute. We capture that information and provide that to the state and the government and the federal government. We look at data reporting and performance interpretation. So we get this information, we interpret it and share with the hospitals, and we'll provide an example of that as well. And then we collaborate with state and other federal partners on what's going on locally and what's going on nationally and how that affects our work here to make sure that our critical access hospitals are up to date with the most current information. So for the core measures, there are basically 12 core measures that as of September 2025, all critical access hospitals are required to report on. You'll see here the measures in blue were added in 2025. And a couple other components to note here. You see those that have 2 asterisks were actually removed from reporting by our current administration last year. A key point is you don't have to report them, but they need to be recording them because that information is needed by these institutions for population health and their own internal quality measurement and management. So they're still here because they're recording them, but they're not reporting them. Those here with 1 star are part of the CMS star rating that our colleague Kathy Roush from Haney's will be reporting on later today. So you'll see that a lot of the measures that we report on cross different programs in different institutions, which is important to understand as we look at how do we evaluate quality in our hospitals. So for some examples, the Quality Improvement Infrastructure Survey is one that is done at critical access hospitals every year. We get that information and we'll show you that report. And it's going to be the basis on how we look at all the hospitals in Vermont. But right now it's just at critical access hospitals. Hospital commitment to health equity, influenza immunization of hospital staff, antibiotic stewardship, safe use of opioids, hospital consumer HCAHPS, which are now a larger component of the CMS star rating, hybrid readmission, SDOH screening and positive SDOH screening. Again, those 2 have been removed from reporting, but not from recording by the institution. The emergency data transfer communication, we'll talk more about that as well. Then time from departure to arrival in the ER, and then left without being seen. So these are all required elements that each critical access hospital must be reporting as of September 2025. And so we've been working with them to make sure that they are reported. And as of this quarter, all hospitals are reporting on all of the measures. It was a heavy lift. So one of the things to understand with this very busy table is that there are many different platforms that each one of these measures gets reported on and many different time periods. So on the far left, you'll see on the measure column, the name of the measure, which are the measures I just shared with you, the domain where it falls in their quality programs, and then the reporting frequency. Notice the critical access infrastructure is every fall, so it'll be coming out in October for all the critical access hospitals. But then the annual influenza is annually by May 15th. Antibiotic stewardship is annually March 1st. So you see February 28th, the quarterly, annual. So they're all different dates and times. Then on the far right-hand column, you'll see that the critical access infrastructure is via Qualtrics from the University of Minnesota. But then the next one is done on the NHSN platform. And if you look down below, safe use of opioids is the CMS HQR platform. So this data doesn't come to VPQHC or anywhere else in the state. It goes to the national platform, which then feeds it back to us. And I'll show you that process as well. The one that we do collect directly is the Emergency Department Transfer Communication, which is done quarterly. They provide that information to VPQHC. We put it into the appropriate format, provide it to the state, which then sends it on to the University of Minnesota for collection and evaluation sent back to us each quarter in that process. So there are many steps, and a lot of these require a manual component to them. It's not just an EMR request to get. There's some manual components, especially EDTC data, which requires a review of what we call a HRSA form, which is a requirement of data elements when a patient is transferred from one institution to another. And I'll show you that example in a minute. You'll notice in each of these slides, which we'll send the updated slide deck to you, there are links that you can get to that will show additional information about each one of these programs to get to that granularity if you're very interested in them. Okay. Hillary brought this up. It was the core elements of the quality infrastructure. This is really critical to understanding how quality improvement and quality assurance happens in an institution. Without these components, it's impossible to have a strong program. And the way this has been set up really ensures that they don't only say they have it, but they actually show that they have this information. So for example, leadership responsibility and accountability. Are leaders involved and engaged in this work? And is the board involved and engaged in this work? Is there a subcommittee of the board? Is quality embedded in the organization's strategic plan? Is it even mentioned in there that this is a focus that we're looking at? Is there a culture of continuous improvement through systems? And then is there a culture of continuous improvement through behaviors? Not only do you have a system, but is there evidence that you're using it? And that's seen as well in the collecting of meaningful, accurate data and the use of the data. The collecting of accurate, meaningful data is quality assurance. You're reporting data, you're monitoring data. The evaluation of that data and the improvements associated with it is quality improvement. So this shows that every single institution needs to have a quality assurance program and a quality improvement program that reacts to the data being generated by the quality assurance program. So this is a really strong tool, and we have this data over the many years for all the critical access hospitals, and this is going to be the basis for the survey for the rest of the hospitals in the state. We get the data on a workspace, a secure workspace that the Vermont Department of Health and VPQHC has access to. Every quarter data is downloaded to us that we get notified for and able to go in to look at it in these categories here. There was a recent change where they changed how they were reporting the tools. So where this looks very messy, the inside of it's even messier because there's a lot of historical files in here that don't look like the current files. I think the change has been for the good, and that we see all the data all the time. It's just not always updated, and I'll give you an example of that. Here's an example of a report. We get reports for the entire state, a summary for the entire state, and one for each individual hospital. So if you look at the top of this one, it says report to 2026. So it was the second quarter of 2026. You'll see down on the left-hand side, what are the measures included in this? But when you take a look at those measures, they're not all current. Some of these measures, if you see on the right-hand side, this is the emergency department transfer communication. It goes back to Q1 of 2025. Some of the other data on this report will go back to 2023 because it's only updated annually. So it'll be 2023, 2024, 2025. The good part of that is that we see it all the time, so it's a reminder that the data is there, but we also have to remember that it may not be the current reported data. Having said that, the data here may not be up to date, but the hospitals themselves will have that current data. There's just a delay in the system on the reporting. So we get these reports like this one here, and we interpret it. We send our interpretation with their individual report back to the hospital. And here on the bottom, you'll see an example of a chart that's provided in these reports, which shows what the US standard is right now for this reporting, what Vermont is. And when you looked at the individual hospitals, it would also have the hospital line. So they're able to look at data over time. And in quality improvement, that's critical to anything. Where have we been? Where are we now? Where are we going? It's critical in continuous quality improvement to monitor those steps in that process. Okay. I don't know if we're taking questions now for this or waiting to the end.
My preference was to wait to the end unless someone had a burning question to do with the slide that's like right here. And I'll trust people to raise their hand if they have a question. So thank you.
Thank you. Thank you. Thank you. Okay, great. Well, then now I will transfer it over to my colleague, Esther, who will talk about the patient safety and surveillance improvement system. Esther.
Thank you, Randy. Thank you, board and public, for giving us this opportunity to share. I am going to, moving forward, refer to the Patient Safety and Surveillance Improvement System as PSSIS, just because saying Patient Safety and Surveillance Improvement System over make us late for dinner. So we'll move forward with the slides and describe to you a little bit more about the PSSIS and what VPQHC does on behalf of the Vermont Department of Health. So under the statute, healthcare facilities are mandated to report their serious reportable events. And I will describe later in our discussion what some of those specifics might be, but everyone is mandated to report their serious reportable events, and the definitions for these reportable events come from the National Quality Forum. We recently updated the use of the 2025 NQF, or National Quality Forum, definitions from the 2011 definitions just in July of this year. So some big changes kind of came around very recently, but VPQHC administers the state's patient safety program by collecting those mandatory reports from hospitals, ambulatory surgical centers, all in the effort to improve patient safety, eliminate adverse events, and support quality improvement throughout. So we really do collect not just their initial reports, but also their completed root cause analysis and corrective action plans, in addition to any intentional unsafe acts that occur, again, at the hospital and ambulatory surgery centers. I think we're going to have to potentially fix our link, but we have links available for you in this deck. The requirements of the PSSIS. So there are 4 pillars, really: reporting, analysis, disclosure, and monitoring, that all fall under that sort of mandated statute. Establishing an internal policy and procedure to identify, track, and analyze all adverse events is part of that statute, part of that obligation. So having some policies in place to report internally, reporting to PSSIS any incidences of intentional unsafe acts and any serious reportable events. They must conduct a causal analysis and file that with PSSIS. They develop and implement a corrective action plan and file that with PSSIS. As far as disclosure, they have to develop disclosure policies and procedures delineating when and how to provide and document any disclosure to patients when a serious reportable event occurs. And then finally, the monitoring. They cooperate with periodic onset monitoring on a 3 to 4 year cycle, where VPQHC walks through what is mandated, evaluates their ability to meet those needs, and offers assistance as needed on meeting those criteria. Next slide, Randy. A culture of safety really is a foundation to everything in this work. It's the hallmark of a robust safety culture in not trying to create the absence of errors, but in the collection of those errors and responding when things go wrong. So it's really about how people work together and making sure that a strong safety culture within each hospital and ambulatory surgical center, as well as within our state, can help provide a transparent event reporting
style, as well as then offer valuable learning opportunities and focus on the systems. So improvement rather than individual blame, and systems approach rather than individual blame. So really working on what is known to be best practice. And again, there are links within this slide deck to help you dive further into detail if that is your desire, but really within VPQHC, as well as the culture and work that we try to do with reporting, is to help facilitate a learning environment. Go ahead, Randy. So what is reportable? I mentioned earlier on that I would describe a little bit more about the serious reportable events, as well as how that's distinct and different, but also important is the intentional unsafe acts. So here we see that the SREs, or the serious reportable events, require a full analysis and action plan, whereas the intentional unsafe acts are reported, but they do not require corrective action plans to be submitted. Both of these reportable style or events do require an initial report within 7 calendar days of discovery. So those have similarities in how they get reported. And then if we break it out, a serious reportable event really is something like patient harm that was associated with a fall in the hospital, or patient harm that was associated with a medication error, either in a hospital or an ambulatory surgical center. Any of those things gets reported, whereas an intentional unsafe act is more of a criminal activity or staff under the influence of a substance. There are instances where an SRE, or a serious reportable event, and an intentional unsafe act may overlap. And so a single event may trigger both a serious reportable event report as well as an intentional unsafe act report. And then on the next slide, we'll kind of walk through what the entire process for a serious reportable event is, and how we are able to help facilitate this work, that it becomes, again, a learning opportunity, not trying to necessarily eliminate any error, but to be able to learn from error and share those learnings. So in a causal analysis, which is required for each reportable event, an interdisciplinary team is expected to meet, including frontline staff, to really understand the entire process that occurred, and emphasis again on that no blame culture, focusing on the systems and the systematic approach to learning from the event that was reported and occurred. Action plans must be specific and measurable, and I think that you've heard that not just in the introductory discussion around the strategic plan, but for all quality improvement. If we aren't specific and delineating those measures, then it's very hard to be able to be effective in action. So in a corrective action plan, we want timelines for completion, assigned accountability. Those are critical within an action plan. Establish a process to monitor the action plan performance, so to ensure that it's having the intended effect. So we at VPQHC will mentor and facilitate any discussion around either of these items once reporting has been initiated, to try to, again, facilitate learning from any event that occurred, a systems approach, and being able to then respond accordingly. Ahead to the next slide, Randy. And every year, what we do at VPQHC is, through the collection of each of those reports, those serious reportable events and the intentional unsafe act reports, we then compile all of the data that we have from the year prior, And we then can break it down into an understanding of the categories of the events that occurred, the events themselves, specifically the severity of the events that occurred, the locations where they occurred, any patient demographics, so that we can really try to understand and again create an environment of learning from what has occurred so that we can then establish next steps as a learning environment in the state of Vermont. So we bring together the quality directors of each of these hospitals and ambulatory surgical centers to be able to discuss our forward thinking and next plans on how to be more effective in preventing serious reportable events. And the next slide, you can see how from the 2025 data that was collected and analyzed, number one, I already mentioned that the National Quality Forum Serious Reportable Events was updated for 2025, and we have been able to implement the new list, the new standards, effective July 1st of this year. But then additionally, we take the information again from the patient safety reports and what we've learned, and we have quarterly meetings, and we take the annual report and we highlight the opportunities. And what we've learned as an example from 2025 is that it may be most appropriate to explore some age-friendly care, mobility, consistent strategies for fall and pressure injury prevention, as those tend to be the highest reported events. And then moving the state and all of the quality directors into a mindset where we're moving from compliance emphasizing quality indicators, quality improvement, moving towards measurable harm reduction. And I believe that is the end of our slide presentation. Thank you so much. And I will go ahead and send it back to you, member teach out and temporary chair.
I love it. Thank you. Hillary is going to introduce our next speaker, I guess, and we'll move on. Unless people had questions here, I was going to hold them all for the end. I realize this is a ton of information that we're getting kind of all at once.
Great. Yes, I'm going to turn it over to Kathy and Colleen from Haney's, and thank you so much for being here. We're looking forward to your presentation.
Good morning, everyone, and thank you for the opportunity. We really appreciate being able to participate in this conversation. For those of you who may not know me, my name is Kathy Rao. I'm the Vice President of Quality Advocacy, Research and Innovation at Haney's, and joining me is Colleen McVeigh. She is our Principal Healthcare Informatics Analyst in the Economics, Finance, and Informatics Division. We're going to provide an overview of the star ratings that was shared earlier this year, and then cover a little information about the CMS pay-for-performance programs. We'll also talk a little bit about the data updates on the CMS star ratings. Colleen's going to go through and talk about the data analysis that she performed. And then, like I said, I'll cover a little bit of information on the pay-for-performance programs on the back end. All right, let's just jump in. So this is a table that we have been using for quite a while just to help keep track of the CMS star ratings methodology changes. Just to note, the program has been in place now for about 10 years. And in that period of time, there have been 5 versions, or we're on the 5.1 version. What we saw was in the Biden administration, there was a significant amount of focus and concern about specifically patient safety in the quality realm. I think for some of you who are a little closer to healthcare quality, what you'll appreciate is in the last couple of years, CMS has been working with measure developers and stewards to develop measures that are much more specific to patient safety. I think there's been this shift, moving a little bit away from, clinical conditions, AMI, CHF, COPD. They're all still there in different ways, but really there is a desire for us to, focus and hone in a little bit more on hospital harm. In that report that the Biden administration's team put together, they made recommendations about really putting an emphasis on the safety of care in different ways, whether it was through the conditions of participation or through programs such as this. And so what went through the rulemaking process last year was that there was a proposal that hospitals in the lowest quartile, meaning the bottom 25%, for safety of care domain performance would be capped at a minimum of 4 stars. And we saw that change take place in this report. So in calendar year, stage 1 was applied. And what that means is that hospitals in the lowest quartile for safety of care was capped at a maximum of 4 stars. I want to just offer that when CMS published the ratings, they indicated that resulted in 15 hospitals nationally being capped at 4 stars. I think again that we're trying to take a little bit of a progressive step, staging this up where we see in the next report for calendar year 2027, the approach will be, or the full methodology change will be that any hospital in the lowest quartile for the safety of care domain will have their overall star ratings reduced by 1 star. So again, for example, a 5-star hospital would go to a 4, a 3 to a 2. Obviously, there would be no rating below 1 star. So I just wanted to mention that to you. And then, Colleen, why don't I hand it off to you to walk folks through the methodology?
Sure. So this slide is going to visually walk you through all 9 steps of the current star ratings methodology. And I'm going to go into a little bit more detail about each. But the first step here includes selecting the measures that are going to go into this program. And that process starts with identifying the universe of measures to be chosen from. And that universe is going to be all acute, inpatient, and outpatient hospital metrics that were reported on Care Compare for the chosen data month that CMS has chosen to run this program on. And in this particular case for 5.1, that's going to be October 2025. So now that CMS has their universe, they then move on to exclusionary criteria. So CMS automatically excludes measures that are structural in nature, non-directional metrics, so metrics that you wouldn't necessarily know if a high score or a low score is better than the other. Anything that is voluntary or just not mandated through CMS is also removed. Any overlapping measures, so measures that have significant overlap to one another. And finally, any measure that no more than 100 hospitals were able to publicly report on. Again, that's a volume issue and wouldn't be a fair comparison, so CMS doesn't include that. So that's step 1. That's our measurement selection. And our current measurement count is 52. Kathy, could you move to the next slide for me?
Sure.
So step 2 is measure standardization. Now that we have our measures, they need to be standardized for better comparison. This is necessary because the metrics that we've selected are looking at different types of units. So some are reported in minutes, others are in ratios or percentages. They can also go in different directions. So for instance, patient satisfaction scores, you want, higher is better, of course, and mortality is lower. So those can be difficult to compare to one another. So to accomplish this standardization, CMS uses a technique called Z-scoring. to make sure that all the measures are on a common scale with a common direction. This process does not change your actual information, it just translates it to a different scale. So in the slide demonstration, you can see why Z-scoring is helpful here, because on the left, if I told you that my hospital had an 84% in responsiveness of staff, you would assume that maybe I was saying the same thing when I said 84% in my communication of medicine. But in fact, an 84 in responsiveness is below average. And in communication of medicine, it's significantly above average. When we switch to a standardized Z-score, I can easily say that a measure is that one or both measures are one standardization above the mean. So this is how we truly compare metrics apples to apples, so to speak. Next slide. So now that we've standardized our measures, we're going to group them into domains. The breakdown looks approximately like this. Mortality and safety of care measures both have domains, both have 8 measures. Readmissions has 11. Patient experience is by far the most heavy, and that is going to be 15 measures, and timely and effective care encompasses 10 measures. These do fluctuate year to year with the number of measures. There's also the option that a facility may not have a score in all of these measures. And we'll get to that when we talk about reporting requirements. Next slide. So now that we have sorted our measures into our domains, we're going to make a group score calculation or a domain score calculation. This is fairly simple. For every measure that a facility receives a score on, CMS averages them all together within each group. So there's an equal weight placed on every measure that you qualify for. For example, the readmission domain has 10 measures, so each measure is weighted at 10%. But if you only had 5 of those, they would be weighted at 20 to make up that difference. So at this point, the domain scores are calculated and then re-standardized. So we go through that Z-score performance again, so that we can more accurately compare each other to the mean. Okay, next slide. So now that we have 5 domain scores, or potentially anywhere from 3 to 5 domain scores, we will consolidate that into one summary score. And in order to do this, CMS weights the domain scores as listed on this slide. So mortality, readmissions, safety of care, and patient experience are all worth 22%. And timely and effective is worth 12%. Once again, as these are calculated, they are weighted by that 12% or the 22%. So next slide. So now we can talk about reporting requirements. All of our measure scores are in one summary score, and that summary score is going to be used to determine your star rating. But first, there's a couple of hurdles, namely these reporting requirements. In order to be eligible to receive a star rating, the hospital must have 3 or more measures in 3 or more groups. And one of those groups has to be mortality or safety of care. This is also the point at which a critical access hospital can voluntarily suppress their rating. I do just want to draw attention to that. Those facilities have still gone through this entire process that I've talked about up until now. It is only at this point that a critical access hospital score would be, quote, hidden. And obviously, it's not really hidden because we're able to access that information in a different location on QualityNet and provide it to you. So yes, that's where that would occur. Next slide. So now everybody who has a qualifying score is going to get grouped into a peer group. whether or not you report on 3, 4, or 5 domains. Once you're separated into those groups, now you can go through the star rating determination. CMS uses a process called K-means clustering, which is a statistical program run through to basically you tell how many groups that you want your data sorted into. It finds statistically relevant scores and then clusters. So that's how we get 5-star ratings in each group. This process results in your summary score being turned into 1 through 5, a 1 through 5 score. Next slide.
I think this is where I'll pick it up, Colleen. Yep. Okay. So it's always important just to be aware of what are the performance periods that are captured in this star ratings. So for the April 2026 report, you can appreciate that the measures no longer fall into the COVID-19 period. You know, when we're in the pandemic, there was a period of time that CMS held quality reporting. So because of that, there were some adjustments that needed to be made, and it did, you know, I think, you know, it was something we were all mindful of. So just wanted to note that there is no longer any measures that fall into that time period. We have now moved past it. But I also want to just call out that you know, we've talked about it before, that the outcome measures tend to go back a little bit further in time than timely and effective care and certainly patient experience. There's also been a 3-year time period for those metrics. So again, those are some considerations when you're looking at the data results to, you know, just be reminded that some of the data does go back a few years. And, you know, again, there's things that have changed in, I'm sure, performance. So you need to be mindful of really that action based on what's going on today versus, you know, maybe what was, you know, going on a few years ago during that period. I just wanted to mention that, you know, there was really no surprise when the report came out that we saw that COVID-19 vaccination coverage was removed. It had been retired from the quality reporting program back in October of 2025, as well as the perinatal care 01 measure, which was retired in January of 2025. So those were the 2 measures that were removed. But what we did see was that the hospital-wide mortality measure was included in this report. I think it's just important to highlight that in this report, what CMS did is they used the claims-based data only for this report, because what CMS has been hearing from directly from hospitals, but also from hospital associations and others, getting those clinical data pieces, which tends to be lab medications, you know, and lab results, those are radiology. Those pieces of information haven't been as easy for hospitals across the nation to be able to submit directly. So CMS has extended that period for a bit of time, but what you'll appreciate is that next year CMS intends to use both claims and clinical data when they are reporting that. I just highlight for our members, I wanted to share it as well. This work really takes a group effort to be able to make sure that those discrete data fields are built in workflows that work for clinicians. So it really takes having the quality folks along with the clinical leadership and IT to come together and to make sure that we're all working together to successfully collect the data that's going to demonstrate the high level of quality care that's being delivered. So that's work that I know many of our members are working on and wanted to just mention here. As Colleen had mentioned, there have been some changes to the patient experience measures this time around, and the HCAHPS measures will now use a linear mean score rather than star-based scoring to give some finer granularity. I think that was something that was being recommended for a period of time, and I know many are happy to see that change has been made. equally, there had been a bundling of cleanliness and quietness plus hospital rating and willingness to recommend. They've now been pulled apart, so you will actually be able to appreciate much more so where the concerns are or the opportunities are related to cleanliness, and quietness instead of them being put together. And then I just want to also mention that linear scoring does have an opportunity to encourage incremental improvements while aligning across your strategies. So just a benefit there as well. I think that this helped us, and certainly I hope it helps all of you to appreciate what those changes mean. Again, you'll see that we have that breakout that I just spoke about. But the other piece that is important to see, that there were some new measures that CMS brought into this domain. CMS has been very eager to continue to grow the outpatient and ambulatory surgery metrics in this report. And so we can see here that there were 5 that were added to this report. This is now the largest domain in the star ratings, with 15, bringing the total number up to 52, which is kind of on the higher side of where we've been compared to other years most recently. So with that, Colleen, I'm going to hand it back to you for the data.
Sure thing. So now we get into the really fun part. So as we go through the data, I'm going to look at a very global view, and then we're going to get more detailed as we go along. So we'll start with actual star ratings, then we'll look at domains, measures, things like that. So comparing state scores to, in general, to the national performance, we can see what we're hoping to see here is a similar pattern of normalcy. So I would expect the national performance to look like a perfect bell curve. And I would hope that an individual state's distribution would look similar. If, for instance, a state's distribution shifted right, so that's kind of what you're seeing here on our Vermont side, that means that a state is performing better than the national average. That means that they have more 3, 4, and 5-star hospitals, particularly 4 and 5-star hospitals, than the nation, based on a percentage, of course. We are seeing a shift at the national level. We're not seeing that perfect bell curve so much anymore, because CMS has started changing those star ratings after they do their summary scoring. So we are seeing more 4-star hospitals this year. And again, that's basically deliberate. But we are also seeing a somewhat significant right leaning for the state of Vermont, with 2 5 and 4 stars, and then 1 2 and 1 1 star. And we'll see how that's a little different than previous years. Could you switch to the next slide? So here we can look at the distribution for national over the past 5 years, and over the past 3 years with Vermont as well. And we can see that in 2024, a perfect distribution. 2025, a little left leaning because you didn't have any 5-star hospitals. And then this year, Vermont has gained 2. So we are seeing a shift towards that right. Next slide. So here, this graph represents the average domain score for all Vermont hospitals in 2026. So we can see at a glance that the domains with the greatest opportunity are mortality and safety of care, whereas patient experience and timely and effective care, as well as readmissions, are performing above average. Next slide, please. So staying at the domain level, but looking at it by hospital, we can see which hospitals may be driving the performance in both directions on the previous slide. So for instance, timely and effective care was identified as a strength in the previous slide, but this is going to be heavily driven by both Gifford and Grace Cottage. But mortality and safety of care are also noted as being an opportunity, and those are also being driven by Grace Cottage. So just please note that I did include hospitals in those averages that did not receive a star rating. And the reason I did that is just because a hospital doesn't have a published star rating doesn't mean that that data isn't available, that it can't be looked at. And frankly, it means that those were still cases of quality that we can learn from. Are there any questions on this slide while I'm here? Or are we holding everything till the end?
I think because it's complicated, if people have questions, just raise your hand. It would be hard to ask a question in 20 minutes from now on this one.
Fair, fair. Okay, so in lieu of that, if you do have any questions, feel free to interrupt me, but we'll head to the next slide.
Can I ask a question?
Yes.
So going back 2 slides.
2 slides.
Sorry, 3 slides.
Okay.
So in 2026, we have, are there 2 hospitals that did not report their star ratings in Vermont?
There are 3. Yes, there are 3 hospitals in Vermont that did not receive a rating, and they are not displayed on this graph.
But when you go forward to that graph.
Yes, so Grace Cottage, Springfield, and Mount Ascutney.
I see, okay.
Are down at the bottom with no rating. You can see that I can see their domain scores. I can see individual measure scores where they're published. They don't receive that rating. That final step.
Okay, and is there a way to interpret what their rating would be, or is that not possible?
There is a way. So the source that I use for this is our statistical package that is on QualityNet. And I can actually see those hospitals' star ratings. Yes.
Okay.
And then just to clarify that
publicly.
Right. And just to clarify, that's on the back end of CMS,
Yes.
that pathway.
Would you mind jumping forward to mortality?
There you go.
Perfect, thank you. So now we've looked at domains, by hospital. Let's step down another step and we'll look at average measure scores within those domains. So in looking at mortality measures, we can see that the greatest strength is mortality for coronary artery bypass graft within 30 days. Whereas the greatest opportunity is stroke, heart failure, as well as the PSI-4. And it is important to note that PSI-4, as well as PSI-90, is a composite metric. So there's actually a lot of stuff underneath that as well. Readmissions. So if you recall, in our domain slide, we identified readmissions as just above average. And the main measures that would be driving down that performance are ED visits for patients receiving outpatient chemotherapy, as well as admissions for patients receiving outpatient chemotherapy, and then hospital return days for pneumonia patients. So it's just interesting to note when we look at some of these where the common themes are, like the outpatient chemotherapy metrics.
Yeah, and the only I just want to add though, before you go forward, Colleen, I do think though, when we look at some of those types of metrics like ED visits for patients receiving outpatient chemotherapy, in some cases, again, it's really trying to look at, what other resources there are in the community to care for a patient who's going through chemotherapy, and kind of again trying to look more at that total care plan, I guess, is what I'm trying to say, right? Sometimes there isn't an option, right, where if somebody is having a reaction to or side effects of, that's the the place where they can go, versus again where there may be more resources or supports in the community itself. It may be again that they are either just not able to access them for different reasons, or so on. So I just want to kind of call out that sometimes when we look at the measures, right, it's kind of having to kind of look at them from who they are, and kind of what are those opportunities, and really walking through them and understanding regionally and locally what might be affecting that result or that number.
I just ask a quick question on that slide before, the
Sorry.
readmission slide? No, no worries. It's hard to see hands raised. Just a quick clarifying question. I can't remember. I think I once knew this, but now I can't remember. When CMS captures readmission, is it readmission to the same hospital or any hospital after a
Colleen.
discharge?
Colleen. Did I lose Colleen? I can't see. I'm sorry, because I'm sharing my screen. Colleen, are you still on?
I don't see her.
You can see her?
I don't see her.
Oh,
So
you don't see her. Okay. I apologize again. I can't see because of my screen, the display settings. I don't want to misspeak. So let me just check in with Colleen when she gets back with us, and we'll make sure we answer that before we close off. Okay.
Thank you.
Okay, sure. Thanks. So without Colleen maybe being still with us, I'll pick up until she jumps in. For patient experience, as Colleen said earlier, we see that this is a real strength in Vermont. Quite honestly, New York State is, I think, actually, if we're not at the bottom nationally, we're very close to the bottom nationally. So just want to acknowledge that this is, typically a really difficult domain for most organizations to have high performance. Now, again, I think it's helpful to appreciate that now that the quietness and cleanliness are pulled out, you can appreciate again that quietness appears to be an opportunity in this report. And for all of us who have worked in hospitals or have been a patient, we appreciate sometimes that gets to be a little tough, too. But we all work on it in different ways. But just want to acknowledge that pairing or pulling it apart gives us a little bit of insights in where the opportunity resides. On the safety of care domain, what we can appreciate is that there seems to have been some good performance, right? Surgical site infections, your central lines, and your hip and knee complications. Where we see there's some opportunity is in the MSRA, bacteremia, your CAUTIs, and C. difficile. Acknowledging, just again for some context, I think that's very consistent with kind of what we've been seeing nationally and even in our own membership. And the patient safety PSI 90 is, again, one of those groups. It's a composite measure. So just understanding it's not just one, something that's being measured. It's multiple events that are being measured. So that's, again, where we work with our hospitals to make sure that they are looking at each one of those measures that make up that composite measure. It's a bit of a tricky one, too, because it's a little bit black boxed in that AHRQ adjusts the numerator denominator exception criteria. So it's really, important for hospitals and quality leaders to stay on top of that information. It's just not as publicly available as some other things are, but it's really, again, where we come in as quality leaders to kind of make sure we're all aware and familiar with what those changes may be, and to work with coding and our providers. Those cases or those events are driven, all by documentation, and we have found, again, I think it's more of a national recognition. Sometimes there's a difference in what is documented and where the coders, are left in that interpretation. So sometimes working together as a team really helps to make sure that the data is an accurate reflection of the care that's being provided. I'm gonna go to timely and effective care. MRI lumbar for lumbar spine for low back pain, again, is a strength. I'll just jump down more to the opportunities, recognizing we're getting a little close on time. We see ED patients left without being seen. Again, I think we all are facing, it's really tough in the emergency room sometimes to move patients through, whether it's being seen, being admitted, being seen, being transferred, being seen, being discharged. So again, I think that that's an opportunity that we are seeing across the board nationally. severe sepsis and septic shock, safe use of opioids, median time from ED arrival to ED discharge. Again, I think that those are fairly common across the board. But what I think kind of jumped out when we were looking at the data was the brain scan within 45 minutes of arrival. Again, we talked about just a few slides ago that there was opportunity related to the mortality for your acute ischemic stroke. So again, when analyzing and looking at those cases, it would certainly be important to be looking at that other aspect of things on the process of care side, right? That being able to get that scan in that timely fashion.
And Member Merman has a question, so let's let him jump in.
Just a real quick question on this. So the MRI for lumbar spine for low back pain, that's the absence of doing an MRI for low back pain?
What they were finding was that, I believe, and I'll verify, but if I'm not mistaken, I think they were seeing a high number of MRIs being performed. And I think that the ask really from CMS was to make sure that it was criteria based. So I will check on that as well and make sure, but I'm pretty sure that's where those radiology measures came from a handful of years ago. Was I think they were seeing some overutilization and was trying to make sure that folks were being cognizant of really the need for different reasons. I'm sure you can appreciate.
Okay, and then the other question I have here, and is this is, and for that metric, would that be just hospital-based outpatient ordering, or does that reflect non-hospital-based outpatient ordering in Vermont as well?
That's a great question. I don't know that off the top of my head, and I would have to do a little homework on that, but I will. I don't know if that reflects provider-based or if it is, to your point, more associated with the hospital and that relationship. I'll look into that for you.
Thanks.
No, of course. Any other questions? Okay. So to kind of bring us back together, what we wanted just to do is give you one slide to reflect what were the top measure scores, and it was the MRI lumbar spine for back pain, which we just spoke about. We see CABG, 30-day mortality, 30-day readmission for your CABG as well. On the HCAP side, professional staff, clean environment, and then discharge information. Where there's opportunity is the PSI 90 that I spoke a little bit about, brain scan within 45 minutes of arrival with stroke symptoms, ED visits for patients receiving outpatient chemotherapy, surgical mortality for serious treatable conditions. And again, I want to flag that is a PSI. So same comments about PSI 90 and the documentation and understanding what the requirements are, because they do change, or just some key points there. And then the 30-day stroke mortality. And then we have liked, to use this as a visual just to help our, members and others on the New York side, just kind of get a better sense of what is the distribution, especially when you look at it in the bar, so when you understand that you're a one-star hospital, it helps to understand whether you're kind of at the lower end of that, or if you are closer to the cusp between 1 and 2 center. So this just gives you a visual of where the hospitals are in each one of those categories. I know it's a little tough to appreciate on the 5, but there's like one on this, one here and here, and then we have 2 that are here and here. So actually 1 on each side. And then in the center a little bit closer, and then 1 here, and then on there in about center for 1. All righty. I know we're trying to hold questions, and I also want to be mindful of time. So I was asked to provide a little information about the CMS Pay for Performance programs. Just quick background, going back 25 years to crossing the quality chasm and to errors human. There really was a plan that CMS would start with pay for reporting requirements. They needed to get everybody on the same page to be able to collect the data, submit the data, and validate the data. As that was evolving, what CMS started to appreciate is that although there was improvement being made in certain with certain measures, mostly the process of care, they saw that quick results. I think they really came to appreciate that they needed to fine tune on some of those other opportunities with a pay for performance approach. So what the programs are intended to do is reward hospitals for delivering safer, high quality, more efficient care. And these programs were adopted back in 2013. I just wanted to kind of quantify that. So there is a Medicare reimbursement aspect of these programs, which brings, if all three programs together, at approximately 6% of an opportunity or a risk, depending on how you're looking at it. So the first program is the value-based purchasing program. It is, and just before I dive in, I just want to say right from the top, each one of the programs were designed differently. So there's a different methodology for calculating performance, and then there's a different methodology for calculating the dollar pieces. So just want to call that out. In value-based purchasing, what the opportunity is that hospitals could earn 2 scores on each measure. There is an achievement score, which gives them the opportunity to compare their performance to peers. And then there is an improvement score that allows them the opportunity to see how they have progressed, compared to their own baseline measures. What CMS does is they use the higher of the two to come up with that score. This program is where CMS withholds 2% to create a national incentive payment pool. This is what we have referred to as a zero-sum program, in that everybody contributes in, and what happens is if you are a high performer, you would be able to you would get back your 2%, and you would potentially earn dollars from those organizations that didn't have as high of a performance score. So that's kind of how that model works. And in this case, we have four domains. We have a focus on clinical outcomes, which includes mortality. And then there is a complication for hip-knee measure that's included. There is, of course, patient experience, safety of care, and then there is in this program an efficiency and cost reduction measure. Each one of these domains are currently weighted at 25% over the last 13, how many years it's been in play. We see it adjust, CMS will adjust whether it's the measures that are in these categories. Sometimes it's been the weighting that has been adjusted based on what they are seeing in the data. But this is the current program in play. I just want to mention that CMS uses a threshold, which is a 50th percentile, and a benchmark, mean to the top decile, to determine how many points are awarded for those scores of achievement and improvement, which I mentioned. And again, once they do that calculation, the hospital is awarded the higher of the two. I also think, going back to what I said for STARS, it's just as applicable for these programs as well, which is to understand the data collection time periods. So what you can appreciate is that for the clinical outcomes, the baseline period goes back to 2016 and ends, I guess, around 2019. And then it goes into the performance period, which brings us in after that COVID exclusion period, which I had referenced. So I just think that's important for everyone to understand, that there is that difference in time when they're doing that comparison. And then we see that, again, safety of care, person and community engagement, patient experience, and the efficiency and cost reduction are a little bit more timely. So there is certainly a bigger lag on the outcomes that we see in this program. I'm going to then go to the hospital readmission reduction program. This program has a 3% reduction, risk. I think that's really important for me to underscore in my time of working in quality. Most of these programs haven't gone that high, and quite frankly, CMS ramped it up really very quickly. So to really influence hospitals' focus on reducing hospital readmissions. The hospital is evaluated by a excess readmission ratio for each condition that the hospital is being measured on. The calculation uses a risk adjustment methodology that is endorsed by NQF to help measure and calculate the excess readmission ratio, which then will include an adjustment for factors that are clinically relevant, including things like patient demographic characteristics, comorbidities, and patient frailty. That ratio is then calculated as the ratio of predicted to expected readmissions, and a determination then is made as far as whether there would be a payment reduction that would be applied. Just to give you a sense of what the current measures are, it's AMI, COPD, heart failure, pneumonia. We have CABG here, and then it's the total hip and or knee complication that makes up this performance or pay for performance program. I also wanted to do a snapshot of the data collection time here. Up top is your performance period, so 2021 into 2024, and then you can see the performance here. Here's your performance period. So it's July 21st through June of 2024. Oops, sorry, didn't mean to do that. I apologize. So again, just to give you a sense of the timing, and then here is your payment period outlined as well. For hospital-acquired conditions, this has been something CMS has been focused on for quite a while. There are actually two ways that CMS has been focused on hospital-acquired conditions. They started with a present on admission approach before they went to the pay for performance. What that means is that there were 14 conditions that were identified, and unless they were documented within a period of time, early in the encounter, CMS wouldn't pay for that secondary condition. And I'll give you an example of pressure injuries was very common in that the assessment would be done, but maybe it wasn't documented that the patient had a pressure injury on admission. And then later, as the patient was progressing during their hospital stay, that condition was identified. The hospital was, quite honestly, treating and caring for that without there being any recognition that it had been present on admission or no documentation of that. So what CMS did then is apply a decision where they would withhold payment for any conditions that occurred during the encounter that were not documented on admission. Just noting, I know it's kind of a little off for a moment, but during the COVID period, we saw nationally that there was a little less of that focus on present on admission, and many organizations really had to reinstitute that work to make sure that, again, that documentation is being done to capture what the patient is presenting with during those encounters. And then to go to the pay for performance side, it is a 1% reduction that's at risk. There are two domains focusing on safety and infections, and the approach here is that there is a DRG penalty that CMS applies. As I said early on, each one of these programs has a different methodology for being calculated. As Colleen had talked about with the Z-scoring and Windsorization, it was, really a way to make sure that we were kind of, looking at all of the data in an apple-to-apple way. They then calculate those scores using an equally weighted average, and then a determination is made of the 75th percentile of the score. And those that are in that worst performing quartile are subject to that 1% payment reduction. This is a situation where there will always be hospitals that will fall in that category. it is an approach that we have and others have asked CMS to go back and to revisit. We think that, again, the bar keeps rising. Everybody is working really, really hard. And, we feel like it's something that is, worth CMS reevaluating now that it's been in place for over 12 years. But I do want to just mention that there is always somebody who will fall into that category and receive that payment reduction. These are the measures.
Can I ask you a quick question on that?
Sure.
Sorry. So one thing that I think we struggle with is thinking about how to use quality in our hospital budget regulation. And so Medicare has decided to do it this way. And I think, you have this relative scale, but either way, the concept is to pay less to hospitals that are struggling with quality, as opposed to pay more to hospitals that are struggling with quality so that they can improve their quality infrastructure. And I guess the question that I have for you is, do you know, barring this sort of that because it's relative, there's always a winner and loser in this, but do you know if, this has been effective at improving quality over time? Has Medicare's methodology been effective at improving quality over time?
I think it's a really great question. I don't know that I, can answer that just, off the top of my head. I think it would be helpful, and I think it's a great question, quite frankly. What are we seeing in those measures? I mean, just being really, transparent in the conversation, measures change, right? They bring them on, they take them out. So, again, it would be having to maybe take a little time to really evaluate that and to see, where, how much have they been able to achieve, right? And again, off the top of my head, I wouldn't want to say whether it's been, positive, negative. I do think more, just from my own experience, I do think that they drive, where, organizations have been able to achieve really positive outcomes. But I will also say that I think that, that goes back to really quality improvement has been a part of our work. So we're focusing on the data. I mean, I'm not saying that the penalty isn't in our minds as quality leaders, but we are really focused on providing that great patient care. So when we're looking at cases that are coming in every day, it's for us to really analyze and to say, how do we prevent that from occurring again? It's really going back to that zero harm, right? That's really kind of what drives us. Again, I'm not saying the dollars aren't important in our thinking, but I do think that, everyone has been working on all of these because they're just important to what we do as clinicians. But I'm happy to.
I guess you mentioned also that the bar has been raised high over the last decade or so. Do you think this, whether it's the money or the reporting and the attention to it, that's lifted the bar? Or do you think it's just that I guess, do you think the scoring is leading to a change in behavior or a change in outcome?
I will offer just from my experience, and I've worked in a couple of healthcare systems over like a 20-year period. I will offer truly that I think that when the value-based purchasing program came out, and it was the first one out of the gate, I do think that there was a lot more focus on it, right? I think it was the first pay for performance, but I also think that being rewarded for doing well was a very, very big driver nationally. I think a lot of people really appreciated to kind of have that benchmarking and to be able to compare their performance, right? How much have we, done compared to ourselves and to nationally? I feel like that was from just my experience where there was this real uptick of watching hospitals nationally start driving down, some of those conditions or those measures. So again, it's hard for me to offer, specifically. I will just offer kind of in a generality, but Michelle Schreiber, who is at CMS, we've invited her to come and talk to us about these and other programs. It might be something that the board would be interested in, inviting her or learning more about. I think she's really transparent, and I think she would probably be the best person, quite frankly, to talk about what CMS has seen, as far as the results in these approaches. All right, if there aren't any other questions, and again, I'm trying to be
I think Randall was going to chime in.
Yeah, thank you.
I just said one thing. I really appreciate that question because when we look at the value equation in healthcare, value equals quality over cost. So cost is a component of that, but you're right in that how do you balance that? Where are the incentives in this process? And how do we evaluate to make this equation work? How do you evaluate quality? What are those key components that we in Vermont define as quality outcomes against the cost? So how much do we spend here? What improvement do we get with that dollar spent? So it really is a critical question. I'm glad you brought that up because that's part of the conversation that this information will help inform, is that value equation is how do we get to the value of quality over cost? How do we get there? So I definitely appreciate the question. And that's just what I wanted to say because it's in the right direction. I appreciate it.
Great, thank you. All right, take it away. We'll keep moving.
Okay, yeah, actually, this is the last slide, just
Okay.
to kind of, again, for this program, wanting to give you a sense of the timeliness. And I think that's, one of the takeaways, right, is all of these programs have different methodologies, some different time periods. It's a lot, right? For everybody to be trying to follow each one. And again, if you focus in on the data that you are using in your quality improvement programs, I mean, that's really your North Star, right? Is to say, this is where we are today, this is where the opportunity is, and you continue to focus on that. And then, if you're moving in the right direction, these pay for performance programs are able to demonstrate the quality of care that your organizations are providing. So again, I think, it's just for quality leaders, it's kind of keeping all those things moving and making sure that we're staying on top of everything. But really, it's about just staying focused on the delivery and the quality. Any other questions?
Are there others?
Can I just pop in with one last one? I'm sorry for taking the floor so much on this, but it's just one quick question. And I'm really happy to see our Vermont hospital star ratings look like they've improved a little bit compared to last year, which is reassuring. One of the things that came up last year or the year before when the star ratings were declining was that our hospitals are saying, well, quality is declining nationally. That's why our star ratings are down. Does that explain why Vermont hospital star ratings with a national decline in quality explain why Vermont hospital star ratings would be down?
Randy, do you have a
I guess in this,
I think I don't think you can say yes or no. I think there are a lot of contributing factors in all of this. I'm happy that we're getting away from the noise of the pandemic. And I think that's helpful as far as to evaluate the data. When I take a look at the most latest report with 3 of the hospitals not getting a star rating, we know that they didn't hide their rating and that they just didn't meet the minimum criteria of reporting each category. But we do have their scores over the years to show that whether they're in those individual categories getting worse or better. So versus saying, geez, quality's gone down everywhere. Yes, and what else is going on in the environment that made this happen? But I think Kathy said it really well. When we take a look at this quality, we are here. If the benchmark is here, how do we get there? And we work with all the hospitals to move in that direction using the most accurate data. What's hard for here in your interpretation is a lot of this data is reflecting work in 23 and 24, early 25, we're in 26. You'll see the results of all the efforts in 26 and 28. So
right.
Having said that, the hospitals who are reporting this data right now have the data that they're continuously working on in their QAPI programs, in their organizations on how they're going to improve it. This just helps them identify where they need to focus, and they can go back and say, how are we doing on stroke? Have we improved in those areas? So it's important data. So there's no real answer to your question of, is it? It's a bunch of things that contribute to nationally it going down, us following that trend. But the real thing is, how do we go from there and up? Because
I appreciate that. I guess my question on that is, if the star ratings are relative to all of the hospitals in the country and they all move one way, then, and our hospitals stayed the same, they would appear, I would think they would appear to have higher star ratings unless they moved further and faster than the average decline, because it's a relative measure. But I think that what I actually took away from that, it would be really helpful for us, I think, to get those individual components of each hospital's quality over time to see where the changes have occurred, even if we don't have star ratings available for them. That I think would be something that would be, I think, helpful for us to start building our understanding of quality and our framework on how to evaluate it in the budgetary process.
And I think that's more meaningful, especially when you take a look at stroke. That stroke measure also would include EMS. How quickly did they get to your institution? You know, and did your institution offer this service, or did they go to your ER and then have to be transferred to another hospital? So there are a lot of structural components to that measure that you don't see when you take a look at what came out of the billing system, that when you're evaluating some of these, you're evaluating the healthcare system, not just the hospital. And that's where some of these combined measures get a little more complicated. I appreciate them. I think they're good because we have to look at the healthcare system, not just the component of where the hospital controls it, and how do we make them work together. So that's a really good value. And you can see that when you look at the individual measures, but not in the total blended, because they get lost. So that's why I appreciate that pull out, so we can understand that complexity and get the right people on board to make sure that, you know, EMS has the ability to transfer this patient to the right institution the first time around, so there's not this delay in care. Those kind of things are helpful.
Great, thank you.
Before I just sign off, I do want to just offer the group a couple quick things. CMS is really sensitive to the lag. They have been hearing for years about the 3 years is way too long. So that is something that was in the proposed rule to shorten that down to 2 years. So hopefully that will move data forward a little bit more real time. I mean, I use that term loosely in this case, but I just do want to reflect that there is an awareness of that. And then the other way that they are looking to make data more real time is through the use of digital ECQMs, which are currently in place, but they are moving very quickly to digital measures. As I mentioned before, interoperability is really the key. And there are some requirements that CMS is just really, quite honestly, they are shoving them forward. They're not waiting for folks to figure it out. They're asking, not asking, actually telling that everybody has to start leveraging that data so that you can have more real-time data to drive the quality of care and address access and other issues. So I just want to mention that, to be sensitive of those things are coming down the pipeline. All right. I thank you for your time. And if you have any other questions, please, you know, through Randy and others, let us know. I know we have a few things we'll follow up and we'll ask them to bring that information back to you. So thank you so much.
Thank you. Really appreciate the time and effort you put into that presentation. So just to keep us moving along, unless there are other questions from the board, I think I'd like to have the next presentation happen. Hillary, I see you on there.
Yes, and it looks like Dr. Weigel, you're ready to go, hopefully. So we'll welcome Dr. Weigel from Vermont Blue Cross Blue Shield.
Great, thank you. And let me just go into full screen mode here, and I should be able to give up about 5 minutes if I do this correctly. Full screen mode, over to Dr. Sarayan. So I'm Tom Weigel. I'm the Chief Medical Officer at Blue Cross Blue Shield Vermont. And I'm just going to spend a few minutes reviewing how Blue Cross is investing in primary care through value-based payments. I'll touch on our 2 current programs, how they're evolving into one unified model for 2027, and how that aligns with the Blueprint modernization work. At its core, value-based care is about aligning incentives between the payer and providers. Instead of simply paying for volume, we're incentivizing better outcomes, better patient experience, and more efficient care. So the goal is a partnership where practices have resources to invest in better care while improving quality and affordability. Everything we're doing is really designed to support Vermont's broader healthcare reform goals. We want programs that are transparent, easy for practices to understand, and aligned with Blueprint when possible. We try to avoid creating another layer of administrative burden. First program I'll talk about is Vermont Blue Integrated Care, or VBIC. This is one of our more advanced collaborative models involving 8 practices and about 18,500 attributed members. So we work collaboratively and regularly with the practices. We provide quarterly performance reports and continuously refine the program together with the providers. We've consistently seen improvement in quality and practice transformation over time. And just as a side note, you'll hear me refer to both VBIC and ECPC. Those are our 2 current primary care value-based care programs. And beginning in 2027, we're combining them into a single value-based primary care model that really more largely follows the ECPC framework while incorporating some of the stronger elements of VBIC. This slide just shows the year-over-year improvements for members, Blue Cross members in the VBIC practices. Nearly every major quality measure is improved from 24 to 2025, including colorectal cancer screening, diabetes care, hypertension control, and wellness visits. Utilization measures are a little bit more variable, but we're encouraged by the movement to lower cost independent imaging sites by over 15% in 1 year. In 2024, we launched the Enhanced Community Primary Care, or ECPC program. This expanded value-based payments much more broadly to all community primary care practices across Vermont. Monthly incentive payments reward quality, encourage appropriate referral patterns, and begin shifting reimbursement away from fee-for-service. One feature that I really like about ECPC is its simplicity. Everything is measured using claims data, so practices do not have to submit any additional reports or information. We aligned our measures with other state programs whenever possible, reduced administrative burden, and focused on rewarding good care rather than paperwork. For ECPC, we now have 113 community practices participating. We use blueprint attribution for the membership. We risk adjust the outcomes and focus these payments on community practices. Practices in ECPC receive an individualized scorecard like the one here on the right, showing their performance against targets and peers along with the resulting payment. So for this, you can see that the practice itself is the yellow dot, the target is the black dot, and their peers are the blue dots. We also give the percentage breakdown for the threshold and the score in that category. And then the per member per month payout on the right. So the zeros are areas where they did not meet the threshold, and then the payout is where they did meet the threshold, and then the total PMPM payout is on the bottom. Per member per month payment, that is. So everything is automated and it's transparent, so practices really know how they're performing relative to their peers and the payment threshold and where improvement opportunities exist. We have also worked with some practices who are close to a threshold to let them know kind of how many members or which members they could focus on to work toward achieving that threshold. And there's a typo here, but as Vermont implements Act 173, which is formerly S197, we see an opportunity to better align commercial payment models with statewide reform. The legislation moves primary care toward more prospective value-based funding, and we think that our experience with VBIC and ECPC really provides a strong foundation for that work. Blue Cross has been a longstanding supporter of Blueprint, contributing more than $90 million since 2008 and approximately $6 million annually today. We also recognize that the state auditor's findings that future success will require stronger accountability and better measurements of outcomes is important. We see Blueprint modernization as really an opportunity to build on what's working while strengthening the performance measurements and demonstrating value through Blueprint. We've been actively working with the Blueprint team, as I think they've also been working with MVP and quite a few providers through their various projects and work groups. We're helping to develop recommendations around payment models, standards of care, quality metrics, access metrics, chronic disease management, and specialty care. And just to wrap it up, Blue Cross does remain committed to investing in primary care and value-based care in Vermont. We believe that the future is better alignment across payers, simpler programs for providers, stronger accountability for outcomes, and continued partnership with both providers and the state. Our goal really is to improve health outcomes, affordability, and strengthen primary care for Vermonters, and with that, investing in primary care, really, again, improving those outcomes for Vermonters. I know I went through that kind of quickly, although I know we're also pressed for time, but any questions that people have?
Thank you, Dr. Weigel. I really appreciate it. And it was interesting to hear your focus on independent and non-hospital primary care providers after the CMS focus on hospitals. So if there's not questions jumping up from the board, I guess we'll move on to the blueprint presentation because we want to hear from everyone and have time unless you have a question. Go ahead.
So you're talking about structural change in primary care through the legislative act. Is $6, it's roughly $6 PM. Is that enough to move structural change towards a more value-based payment system?
Sure. So I don't know if Dr. Saroyan is going to present numbers, but I think the blueprint is working with rural health transformation dollars. And I don't want to, I think that the numbers are much larger for that, just for the patient-centered medical home payments, and also the community health team, the CHT team payments. So I think that the goal overall is to move from what might be maybe 6 or 7% of dollars going to primary care to maybe closer to 10, 12, 13% of dollars going to primary care. At the same time, it would be good if that doesn't increase our overall spend on healthcare, but rather, shift spend from maybe hospitals and specialty into primary care, with the goal of, preventive medicine and reducing costs overall.
Okay. Thank you again.
Wonderful. Dr. Saroyan and Aaron Just, I believe, are on the line. Dr. Saroyan, I welcome you to jump in here. Glad to have you.
Thank you, everyone. John Saroyan, Executive Director of Blueprint for Health. What a great lineup of presentations you all have invited and had delivered. It's really reminds me of a symphony with a lot of really skilled sections coming together to see how they can create better harmony. And it's been very informative and educational too, to be reminded of the many different fronts which this work is advancing on across the state. Aaron Just, who I will introduce in just a moment, and I have prepared this slide deck for you to review at a high level the infrastructure supporting our patient-centered medical homes and advancing high-quality care for all Vermonters. The Blueprint's mission is to steward collaborative, high-value, whole-person healthcare by supporting local providers to improve access and incorporate community-based services. Our vision is that every Vermonter receives person-centered, integrated care that meets their physical, mental, and social needs. And our values, very much in the spirit of which we were invited today, are collaboration, firstly, as well as adaptability, accountability, learning, and evolution. If you'd advance it, the slide, Aaron, that'd be great. So for those of you who haven't participated in one of our educational sessions about the Blueprint, I certainly welcome you to visit our website. We have every quarter an education and training session that's open, and I will put that link in the chat. But if we were to present a thumbnail, the Blueprint for Health is Vermont's statewide practice transformation initiative, advancing high-quality, coordinated, patient-centered care that improves health outcomes through aligned investment, integrated care teams, quality improvement, and community partnerships. And it looks like chat is turned off. So I will give this link to you, Hillary, and let you share it with the public as possible, and turn the rest of our presentation until the end, while I'll make some comments, over to my colleague, Erin Just. Erin.
Thank you, John. Thank you, members and public, for allowing us to present today. And we wanted to ground everyone in the model that the Blueprint for Health uses for practice transformation. So the Blueprint model is really built on 6 complementary supports that enable primary care and specialty care transformation. And none of these components alone transforms care. Together, they really enable practices to deliver that comprehensive and advanced care services that we desire for Vermonters. So it essentially starts with the evidence-based models and standards of care that we have reviewed, along with numerous stakeholders, to ensure that we are selecting standards and models of care that move forward our access, outcome, and value objectives. So some examples of these are really based in the programs that we've designed. So patient-centered medical home, where we use National Committee for Quality Assurance standards. Our approach to medication for opioid use disorder has been to adopt office-based addiction treatment model, addressing pregnancy intention through same-day long-acting reversible contraceptive access models. We implement community health team models, and we have been working over the last few years around implementing the primary care behavioral health model. To support that, we have payment, which one of the key factors of success of the Blueprint has been multi-payer support. So we have participation of Medicaid, commercial payers, and up until recently, Medicare. Now, our payment models offer a combination of payments, which are typically prospective. So it gives practices the ability to provide or to receive per member per month payments for capacity. We also provide payment that goes towards staffing care teams, and we support outcome, not only performance, but improvement over time through our outcome payment program. We also provide direct staffing to primary care practices, and this is our community health team model. So practices that are participating in these models may receive a combination of supports in their practices that include nursing care coordinators, social workers, mental health substance use providers, and other health professionals based on local needs. And these these providers and staff members are able to see any patient regardless of their insurance status. Data and analytics is another component of our program that is critical. So the Vermont Blueprint administers a statewide CAHPS survey for primary care. We use clinical and claims data to measure clinical quality measures, and we have numerous mechanisms of performance feedback. And something that was mentioned early is that the last few years we've been very focused on supporting practices in developing their own capacity to monitor this through eClinical quality measures. Quality facilitation is our next component. So we have a team of 12 quality improvement facilitators that work across the state with between 12 to 18 practices and community organizations. And they're really our change agents. They provide quality improvement coaching, support practices in redesigning workflows and implementing changes, and help disseminate learning across practices. And finally, community partnerships. We have local leadership in every corner of the state. Their role is to really stay connected with all of the practices and providers, connect healthcare and community services, and form community collaboratives to address the wicked challenges that each community faces. So while many of the presentations that preceded us really focused in on quality measures, what I'm going to speak to looks a little bit different, because what drives our quality approach is slightly different from if measures are driving care. So while we do use measures and increasingly for primary care practices, that is essential for their overall financial sustainability. What we've noted is that focus really shifts on what the measure of the moment may be. And in the blueprint model, we really try to focus on what patients and communities need and how to support building the capacity for that. Often we note that improvement efforts can then be measure my measure, whereas with the Blueprint for Health, we're really trying to build the foundational capacity to organize the care that Vermonters receive around a comprehensive team-based care model. Success often gets defined by individual metrics if we are only focusing on measures. Well, when we look at overall functioning of a practice, success is defined more holistically. And with changing priorities and different programs, it's very challenging for a lot of practices to really make those continuous improvements over time. So if the practices establish this strong model of care, they're able to more easily adapt to emerging priorities while maintaining the core functions of a patient-centered medical home. So quality improvement facilitation, what the Blueprint for Health provides is a free resource to practices where we have longitudinal relationships. So these quality improvement facilitators in every corner of the state work weekly, bi-weekly, monthly with practices. They have a variety of clinical, quality, and administrative backgrounds and training in various quality improvement methodologies. They really help create a local network for all of their practices so they can disseminate what things are working well in the different practices across the practices in their health service area or disseminate that across the state. And we really focus on model implementation and continuous quality improvement. So while we have these models of care that we prioritize, and what we've really also grown into is supporting primary care practices in meeting the variety of quality requirements that may be either externally driven because of an ACO program that they participate in, or because they're a federally qualified health center and HRSA requirements that they need to meet, or it could be an internal priority that their organization has determined that is the area of focus. And what we've noticed over time is that our quality improvement facilitation has really, when we are looking at measures and where practices are focusing the most on measures, what's getting paid gets done. So whether that is something that has grant funding associated with it, or is a performance payment that's associated with an ACO or a various program, or something that carries downside risk, or something like the MIPS program, practices are really focusing most on those. Now, our quality facilitation, again, we are focused on building capabilities first and foremost, and then supporting the outcomes and improving upon those. So some of the things that don't necessarily get easily measured, but are being built and continuously improved upon are things like population health management and team-based care coordination across the continuum of care, building capacity within practices to use data for continuous quality improvement, using patient experience and feedback in order to make modifications and shared decision making and access improvements, and really focusing in on how to use the data that they have available to them to monitor and adjust what they are doing. So our impact has been widely documented over time in a variety of different forums. We believe that the evidence reflects the impact of Blueprint's integrated infrastructure. So quality facilitation working alongside data, payment, and care teams. Research has shown that Blueprint-supported practices achieved higher performance on preventative and chronic care quality measures, reduced inpatient utilization, lower healthcare expenditures, greater improvements as practices matured within the Blueprint model, and stronger capacity for population health management. And just to go a little bit further on this, I recognize that this article is now getting a little bit aged, but this was early in the implementation where we still had a comparison group. So at the current moment, we have over 120 practices that participate in Vermont Blueprint for Health patient-centered medical home model, which we believe to be somewhere between 80 to 90% of overall primary care in the state. So we did have the ability to do some research that allowed us to compare participating to non-participating practices. And we really were able to look at things like total medical expenditures per member, inpatient utilization, outpatient utilization, pharmacy. We looked at things like resource utilization index based on methodology through health partners, total care, relative resource values, and a number of key measures that have remained relevant over time. So preventive measures such as breast cancer screening, cervical cancer screening, diabetes care, hypertension control, well child visits. So this study specifically found that by the second year after practices achieved their patient-centered medical home recognition, total expenditures were significantly lower. Inpatient and outpatient hospital utilization declined, resource use index decreased, and participants maintained higher performance on 9 out of 11 of the preventive care quality measures compared to our comparison group. So, Dr. Weigel, thank you for referencing the Rural Health Transformation Program, the partnership that we are continuing on. The Rural Health Transformation Program allows Blueprint to strengthen and not replace its proven approach. So the patient-centered medical model has certainly allowed us to move the mark on a number of things, but there are a number of key priorities that we do want to further improvement upon. So things such as access to primary care, access to specialty care, and care outcomes for priority chronic conditions. So within this design, we're incorporating elements of what capabilities the practice should be developing, how we are supporting that through payment, how we are supporting that through staffing, and how quality facilitation will support practices in adopting these practices, monitoring how they're doing, and continuously improving over time. So at this point, we wanted to reflect on what's enabled our success. Our program is over 20 years old, and I think there are a number of lessons that we can take away over from these last 2 decades. Blueprint has really shown that practice transformation is most successful when 4 elements work together. And the success of Vermont's patient-centered medical home model has depended not on a single intervention, but on a policy environment that enables practices to improve over time. So that includes aligned policy and regulatory expectations that reduce the fragmentation and support common goals. So that has involved a lot of work with our payers and the various stakeholders who set direction for quality measures and focus. Sustained investments in practice infrastructure, which includes how we fund data and EMRs and the care teams that surround the primary care providers and specialty care providers, and the quality resources that we support practices with. Having timely and actionable data and shared accountability to identify opportunities and measure progress, and local flexibility that allows practices to adapt evidence-based approaches to the needs of their patients and communities. So to go a little bit deeper on that, I think the lessons that we wanted to reflect back to the Green Mountain Care Board as you really think about your role and how we can work together and support one another is that what we have found over time is that reducing variation by having practices work toward a common set of quality goals is highly supportive. So practices may be subject to over 120 reporting or payment quality measures. And it can be very difficult for practices to do well on that if they are spread so thinly across a variety of different measures. So every hour spent reporting a different measure is an hour not spent improving care, is what we like to say. So the more that we can align and condense what our priorities are, the more success we see. We see support for core statewide quality measures. We try to work with our partners to reduce duplicate reporting requirements, encourage alignment among commercial, Medicaid, and Medicare initiatives, and really trying to work to support the specifications that we use. So even if we may be focusing on the same measures, we might be all measuring them differently and having different timeframes and data sources. So as referenced earlier, we're really trying to support this transition to electronic quality measures and standardized measure specifications for claims and clinical measures in the interim. Incentive alignment. So I think encouraging payment approaches that reinforce quality improvement priorities. So based on our population health data, we really know that there's great opportunity around cross-continuum incentives for cardiovascular disease, diabetes, COPD and asthma, congestive heart failure, mental health, substance use disorder, and prevention and screening. Comprehensive and access to timely and actionable data. So this quality improvement ultimately depends on complete and timely information. So our continued support or shared support for levers to increase opt-in population contributions to our statewide data sets is important, so that we're not missing key segments of Vermonters. Supporting clinical quality reporting, so that more work can be done behind the scenes versus having to go into practices and do chart audits. Data integration across systems is going to be key, population health analytics, and near real-time feedback to practices. Local investment in continuous improvement and not just performance. So many payment models reward outcomes, but don't provide as much support for the work required to achieve them. So the Blueprint for Health has found its success, and we support models that invest in clinical data systems, practice facilitation, quality coaching, learning collaboratives to share and disseminate best practices, team development and training, and allowance for clinicians to spend more of their time participating in the quality improvement efforts. And supporting long-term sustainability. So transformation takes time. I think one of the key factors of Blueprint success has been that there has been a relative amount of stability over the focus areas and incremental change over time, rather than frequent shifts in the priorities that are seen.
Sure. Yeah. Thank you, Erin. That was fabulous. Tour de force. Thank you for doing that in such a short amount of time. Really appreciate it. We have opportunities that can amplify this work and collaborate. I know Erin, in her previous role, annually convened many different parties, payers, organizations, including those we've heard from today, in a quality measure crosswalk, which is published on our website. I think the
2025 version is on our website. 2026 version is coming soon.
Very soon. Yes, I just saw a draft of it. We have Blueprint for Health Executive Committee meeting every other month, which is tomorrow morning from 8:30 to 10, which Member Merman, thank you, represents the Green Mountain Care Board on. We're very fortunate that the Vermont Steering Committee for Comprehensive Primary Health Care is so active under the leadership of Dr. Faye Homan, who's also on the Green Mountain Care Board Primary Care Advisory Group. And we're very fortunate that we have Elena representing the improvement or the increasing access to primary care in our advanced primary care transformation work groups. All of these streams of work or committees will be continuing, and we look forward to further collaboration with you all. And I think Erin and I will stop there. Thank you, Erin.
Thank you. Thank you, Dr. Saroyan and Erin. I really appreciate your presentation. I don't know if the other board members have questions now for you or for anyone else who presented, if they're still on. I really do appreciate the time everyone's put into this, and to, talking about quality all together at one time really gives us some perspective across the system. No more questions? Okay, great. Thank you. Hillary, is there anything else? Or if there is nothing else, okay, she's smiling. That's good.
No, nothing else. This was
Okay.
a really wonderful chunk of time together. So no, just in my closing remarks, I want to thank, each of the presenters today. And this was a lot of content, and there's a lot here that we can continue to learn about and think together about, and continue to discuss. So also thank you to the board members for your questions and engagement today. And yeah, just look forward to continuing, this work and the partnership and opportunity that is ahead.
Great. Okay. Fabulous. So thank you, everyone who's here, and I will call for a motion to adjourn the hearing for today.
So moved or seconded, however you'd
Okay.
like.
Let's do the second. I moved, you second, and
Okay, sounds
all
good.
in favor.
Aye.
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 Aye. Aye. Thank you so much. Have a great afternoon.